one thing is very important. We have tons of proof of principle trials on patient cohorts of 5 to 20 patients. And that does not get us from the labs into clinical practice at all. We know that from any other therapy in neurology or in medicine, you need class 1 evidence at some point. You need sufficiently powered trials, multi-center trials, blinded trials. So, and this is really a key trial on this, because it's probably with this, in respect to this kind of approach, is the largest trial that was ever done. And the data is really solid, very solid. So we have a clear result, in this case, a clear result that it didn't work. So, so it shows that it is feasible to do this kind of trial. I think we need to get even better and internationally better networked to be faster on these trials. I mean, this trial took 10 years, so it would be nicer to have the same thing done in 2 or 3 years. I don't think that the method is quote unquote dead, because I think there are many alternatives that we could pursue in order to make this work. So, for example, we used 1 milliamp. And this is also for a good reason, because there are some studies out that show that we have lasting effects with 1 milliamp if we apply it for 20 minutes to the motor cortex. But there's also studies out that use now in small studies on physiology that use 2 milliamp. So maybe we should have taken a higher current strength. That would be one option. The other point is, we meant it very well, and we introduced this extremely standardized and very thorough and intense training protocol in both arms. And this applied relatively early after stroke. In the first 20 days, we started usually. So on average, we started at day 20. This may have caused a ceiling effect. Because if you apply a maximum amount of therapy already, of course, it is more difficult to prove that an additional adjuvant therapy, like in this case, brain stimulation, helps. So this would be one possibility of a ceiling effect. The other ceiling effect could be because our patients were treated relatively early, so in the subacute phase after stroke. And this is the phase where after a lesion, motor cortex and other structures of the brain are already maximally stimulated due to all kinds of neurochemical factors and transmitters, that there's probably a phase of a maximum of plasticity already due to the lesion. And maybe it's actually a phase where it's difficult to add on a lot of effect by neurostimulation. And in fact, some of the previous smaller studies were done in the chronic phase, so after half a year or 1 year after stroke, and there we saw some effect. So maybe you could also see that this is a ceiling effect because of those naturally occurring amounts of plasticity in the cortex. I don't tend to see it this way, but it's a possibility. Another point is, this was a very extensive protocol, and our patients were patients with mild to moderate stroke. There's also a possibility that this causes some kind of ceiling, because if they're already relatively good in terms of NIH stroke scale score was 3.8 on average. So that's not a very severe stroke. On the other hand, the Vogel-Meyer arm scores were definitely affected. So it was not like they had no deficit in upper extremity function, because that was basically what we included them for. So the criterion for inclusion was they must have had upper arm dysfunction, and the Vogel-Meyer in the two groups was around between 35 and 40 for the arm score. Out of 66, that's not little. So they had a deficit. Still, we have to say it applies to a cohort of mild to moderate strokes. We do not know if in severe strokes this would have a different effect.